After chemotherapy, patient's bone marrow is destroyed. Neutrophils are crashing, and the infection window is opening. And there is one drug that can change everything, and that drug is G-CSF. And by the end of this video, you will know everything about it, what it is, how it works, when to use it, when not to use it, and one timing rule that can make or break patient safety. So today we are doing a deep dive into G-CSF, granulocyte colony stimulating factor, and this is one of the most important supportive care drugs in all of oncology. You will see in almost every chemotherapy protocol. So first, what is GCSF? The full name is granulocyte colony stimulating factor. And the first thing I want you to understand is that this is not a foreign drug. This is something your body already makes it. It is an endogenous glycoprotein, a protein that is naturally produced in own body by monocytes, macrophages, and endothelial cells and fibroblasts. Its job in the body is simple. Tell the bone marrow to make more granulocyte, specifically neutrophils, and release them into the bloodstream. Now, in pharmacology, when we say GCSF, we are referring to the recombinant synthetic version of the same protein. Scientists took the natural GCSF gene, put it into bacterial cell line, and produced the protein in large quantity. So we can give it as a drug to patients whose bone marrow needs support. So think of this way. Your body already has a natural system to produce neutrophils. Now GCSF is how we turn that system up to maximum when the bone marrow has been damaged by chemotherapy. Now let us talk about actual drugs. There are three main types of GCSF you need to know. The first one is filgrastim. This is the first generation GCSF. It is a non-glycosylated recombinant human G-CSF, meaning it is produced in E. coli bacteria because it is a short acting with a half-life of only 3.5 hours, and it's need to be given as a daily subcutaneous injections. The second, the one you will see most commonly in clinical practice, is paclitaxel. This is the second generation. So what they did was take filgrastim and attach polyethylene glycol molecule to it, and a process called pegylation. This one change makes it long acting, and the half life extend to 15 to 80 hours. Because it lasts so long, you only need one injections per chemotherapy cycle, not daily injections. And it is self-regulating. So as neutrophil counts recover, the drug's own clearance increases, so it naturally stops working when it is no longer needed, and the body regulates it. The third one is lanograstim, a glycosylated recombinant GCSF produced in Chinese hamster ovary cells. It has similar efficacy to filgrastim, and it is used in some European countries. Now the mechanism. How does actually this GCSF actually work? So there are some steps how it works. First, it binds to specific G-CSF receptor on the surface of neutrophil precursor cells sitting in the bone marrow. These are the immature cells that will eventually become neutrophils. This binding trigger a signaling cascade inside the cell, and the first resulted proliferation. More neutrophil precursors are produced. The marrow starts making more of these cells than it normally would. Third, at the same time, this maturation is accelerated and the precursor cells develop into fully functional neutrophils faster than the normal time frame, and a process that normally takes days is compressed. GCSF also enhance the functional activity of mature neutrophils themselves. They become better at killing bacteria, so not only do you have more neutrophils, you may have more effective ones now. And finally, this GSF promote the release of mature neutrophils from the bone marrow into the bloodstream. So it essentially open the gates. The net result of all five steps, ANC rises faster than the chemotherapy and the duration of neutropenia is shorter. The window of vulnerability is smaller, and this is exactly what we need at the time. Next, now the big question is, when do we actually use GSF in oncology? So there are five main situations where we actually use this. The first one is primary prophylaxis. This is when we give GCSF before any episode of febrile neutropenia has ever occurred. The indication is when the chemotherapy regimen carries more than 20% risk of causing febrile neutropenia. Example, high risk regimen includes CHOP for lymphoma, TAC for breast cancer. So, GCSF is started 24 to 72 hours after the last dose of chemotherapy and continue until ANC recover. Number two, secondary prophylaxis. So, this is when a patient has already experienced febrile neutropenia or severe neutropenia in a previous cycle. Even if the regimen originally had less than 20% risk after one episode of febrile neutropenia, GCSF is added every subsequent cycle going forward. And one episode changed the game. Next, therapeutic use. When a patient develops severe neutropenia or febrile neutropenia, GCSF is given to speed up recovery. It is most beneficial when neutropenia is expected to be prolonged more than 10 days. Next, dose dense chemotherapy. So, this is something students often don't connect to GCSF. Some regimens are intentionally given every 2 weeks instead of every 3 weeks. We call these dose dense regimen. And this more aggressive schedule is only possible because GCSF is given to ensure the bone marrow recover fast enough between cycles. Stem cell mobilizations. So before an autologous stem cell transplant, high dose GCSF is given to push hematopoietic stem cells out of the bone marrow and into the peripheral blood. Once they are in the blood, they can be collected by a process called apheresis and stored for later transplantation. And the dose used here is 10 micrograms per kilogram per day, much higher than the standard chemotherapy support. So these are the where we can use it. Now let's talk two drugs. If we'll go with compare with the dosings, so we'll take here two completely different schedules. The one is filgrastim. Standard dose is 5 microgram per kilogram per day given subcutaneously. You start at 24 to 72 hours after chemotherapy and continue daily until the ANC recover to above 10,000 per microliter. And after the expected NADE, not 1500 to 10,000. Wait until full recovery before stopping. For stem cell mobilization, the dose grow up to 10 microgram per kilogram per day. Next, we are taking pegfilgrastim. So fixed dose of 6 milligrams subcutaneously once per chemotherapy cycle. Same starting now. Same starting window 24 to 72 hours after the last chemotherapy dose. For pediatric patients under 45 kilogram, it is weight based at 100 micrograms per kilogram. And the most important dosing rule for this pegfilgrastim is it must never be given within 14 days before the next chemotherapy cycle because it is long acting and it is still working for weeks. So if the next cycle of chemo starts while this is still active, you have a serious problem. So next comes critical timing rules. Now this is the slide where I'm going to tell you why what is the critical timing for giving this GCSF. So rule number one, never give GCSF within 24 hours before chemotherapy. Now here is a logic. GCSF tell the bone marrow to start producing neutrophils rapidly. To do it, it pushes neutrophil precursor cells into active division, and chemotherapy kills rapidly dividing cells. So, if you give GSF just before chemo, you are stimulating cells to divide and then immediately hitting them with a drug designed to kill dividing cells. So, the result is more bone marrow damage, not less. So, you have made things worse, not better. So, we should never give it within 24 hours. Rule number two, never give GCSF within 24 hours after chemotherapy. Same reason, residual chemotherapy is still active in the body for hours and after administration. So, GCSF stimulated cells that start dividing cells will run into that leftover drug and same danger will be there. Rule 3, pegfilgrastim must not be given within 14 days before the next chemotherapy cycle because it is long acting. Even if you gave it correctly after the previous cycle, it may still be working weeks later. So, if the next cycle of chemotherapy starts while pegfilgrastim is still active, those GCSF stimulating dividing cells are going to be hit by the new chemotherapy dose, and you need that 14 days gap to be safe. Now, coming to side effects. What are the side effects? Because the patients will experience this and they need to be counseled before they start. So, first is bone pain, the most common. This is a side effect almost every patient on GCSF experience. What happens is this is rapidly expanding the bone marrow, producing cells at a much faster rate than normal. And this expansion causes pressure inside the bones. Patient feel pain most commonly in lower back and pelvis, sternum. So this can be managed. This can be managed with paracetamol or NSAID. Loratadine, an antihistamine, has also shown benefit in some studies for GCSF, introduced pain, bone pain, whatnot. Next is injection site reaction. So redness, bruising, pain at the injection site, so for that, rotate the injection sites. Splenomegaly, this is rare, but I need you to know because it can be life threatening. GCSF causes the spleen to enlarge as it processes a large number of cells being produced. And in rare cases, the spleen can rupture. So, a patient on GCSF who develops sudden severe left upper quadrant pain, do not dismiss this as a bone pain. And this is a medical emergency. Refer immediately. Capillary leak syndrome, very rare. Fluid leaks from blood vessels into surrounding tissues, causing hypotension, edema, and low albumin. Sweet syndrome, a very rare skin condition called acute febrile neutrophilic dermatosis. Rare but associated with GCSF. Aortitis, rare inflammation of aorta. Present with fever and back pain, diagnosed on CT scan. And some pulmonary side effects, rare cases of ARDs have been reported. Then the slide is this what GCSF does not do. So this also we should know, which is the next slide I'm going to explain now. GCSF does not help platelets. It only stimulates neutrophil production. So thrombocytopenia still happens at nadir. Your patients can still have a platelet crash at day 10 to 14 even if they are on GCSF. So platelet need completely separate management, either platelet transfusion or any other thrombopoietin receptor agonist. So GCSF does nothing for the platelet. Next, it does not help red blood cells. So anemia still develop over multiple cycles of chemotherapy. So EPO agents or transfusions are needed separately. GCSF doesn't have any role here. GCSF does not treat any kind of infection. This is critical. GCSF speed up neutrophil recovery, but it is not an antibiotic. So in febrile neutropenia, antibiotics are the primary treatment. GCSF is supportive. It helps the immune system recover faster, but it cannot replace the antimicrobial therapy. So GCSF address one cell line, neutrophils only. Everything else needs its own management. Now, there is another one is GM-CSF. Sometimes it will get confusion also. So what is this? GCSF is granulocyte colony stimulating factor, specifically stimulates neutrophil productions. This is what we use routinely in oncology for chemotherapy support. Drugs like filgrastim, pegfilgrastim. GM-CSF is granulocyte macrophage colony stimulating factor, and this stimulates both granulocytes and macrophages. It has a broader effect. The drug is sargramostim. GM-CSF is used mainly after bone marrow transplant and in specific clinical setting. It is not used as commonly as GCSF is standard chemotherapy support. So simplest way to remember is GCSF, specific to granulocyte, mainly neutrophils. GM-CSF is broader granulocytes and macrophages. So in routine oncology pharmacy practice, GCSF is what you will encounter. But you should know both GCSF and GM-CSF. So before I'll finish this, some clinical pearls which I want you to know. These are some clinical pearls which will be useful during this oncology uh, postings or when you are in wards, when you are going through some patient cases. So, Pearl 1, always check GCSF timing relative to chemo before dispensing. So, always check the timing of GCSF, which is related to chemotherapy. This is primary verification duty. Second, Pegfilgrastim is preferred over filgrastim when patient compliance with daily injection is a concern. So one injection per cycle versus daily injection, the patient adherence is much better. Third, bone pain from G CSF is not an emergency, but if not counsel, means if the patient doesn't know before they start, they will get panic. So patients should know it. Then, if a patient on G CSF calls it severe left upper quadrant pain, splenic rupture before anything else should be in mind. So do not reassure them it is just bone pain without ruling this out. So refer immediately. Next, G-CSF does not prevent thrombocytopenia or anemia. It only addresses neutropenia. For biosimilar substitution, filgrastim biosimilars are considered interchangeable in most guidelines. But always check institution policy before making any substitution decision. Document G-CSF administration timing in every chemotherapy cycle. This is one of the most commonly flagged issue in oncology pharmacy audit. If the timing is not documented properly, it looks like an error even when it was not. So these are the things about G-CSF. G-CSF is not a supportive care drug. It is a drug that makes modern oncology possible. Without G-CSF, we could not give aggressive regimen like CHOP or TAC. Know the timing rules: 24 hours before and after chemo, 14 days for paclitaxel. Know the indications: primary prophylaxis, secondary prophylaxis, therapeutic dose dense, stem cell mobilization. Know the side effects: bone pain is common and expected, splenic rupture, and know what it does not do. It does not help platelets, red cells, or infection directly. So this is all about GCSF.